In March 2017, 6 months after starting sunitinib, the patient had further increase in abdominal pain, evidence of progression on CT scan with new liver metastases, and decline in performance status to ECOG PS of 2. Sunitinib was stopped and she was started on regorafenib, 160 milligrams days 1 through 21 every 28 days. She had side effects with the regorafenib, including palmar-plantar erythrodysesthesia, in other words, pain in the palms and soles, also increase in fatigue. Regorafenib is a standard third-line treatment. The treatment sequence generally is imatinib, followed by sunitinib, and followed by regorafenib. Regorafenib was studied in the third-line setting after progression or intolerance to imatinib and sunitinib and showed significant improvement in progression-free survival. Now, this was a pretty advanced, aggressive population of patients, so the median PFS on placebo was only 1 month versus roughly 5 months with regorafenib. Regorafenib is approved both for colorectal cancer and for GIST. Most physicians have a bit more experience with regorafenib in colorectal cancer, but with GIST patients who often tend to have a fairly good performance status and are fairly healthy even in the third-line setting, the drug tends to be fairly well tolerated, although there are important side effects to consider. So one of the more important side effects is hand-foot syndrome. This is something that we tend to have to reduce the dose for in many cases, although there are other strategies that patients can use to manage hand-foot syndrome, including daily moisturizing, wearing comfortable socks and shoes, trying to avoid calluses. Liver toxicity is an important side effect to be aware of, and patients need to have their LFTs monitored closely. Similar with blood pressure, we often encourage patients to get a home blood pressure machine so they can self-monitor and notify us if their blood pressure becomes quite high. Tiredness is another challenging side effect, but usually these side effects can be overcome with education and with dose reductions in some cases. We've seen several patients who have progressed relatively quickly on second-line sunitinib who have actually had very prolonged durations of stable disease on regorafenib. So despite the similarity between the drugs, there's probably some biological differences that explain why some patients do better on regorafenib. Some of the side effects from regorafenib are very acute. Liver toxicity tends to occur early. Hypertension tends to be a very early side effect. And hand-foot syndrome often occurs within the first cycle, although it can progress with subsequent cycles. Tiredness is sometimes something that develops slowly over time. So it's important for patients to recognize and report their side effects before they become too severe. So using hand-foot syndrome as an example, you don't want to wait for the condition to evolve into a grade 3, into inability to walk, major blisters and calluses. Patients should report their side effects before they become that severe so they can take a break, probably resume at a lower dose. The standard starting dose of regorafenib is 160 milligrams, days 1 through 21 every 28 days. Because of the toxicity profile, we sometimes start at a lower dose. In fact, in some cases, we start at 120 milligrams, especially in patients who are older, more frail, poor performance status. And in patients who are started on standard dose, we often reduce the dose for toxicity. In patients who experience excess toxicity on 160 milligram dose, we often reduce to 120. In many cases, we reduce down to 80 milligrams. And we have some patients who have done very well for a long period of time on even 50% of the standard dose.